I am indeed.
Okay, good.
I'll just hit record.
Yep, I just okayed the record.
Excellent.
So you want them to do the evaluation and stuff at the end, right?
Yeah, I will set all the links up and have them put in the chat,
Okay,
and they'll also be sent out in the email out as well.
okay, thank you. I realize sometimes I don't know, I sound like I don't know what I'm doing, so I'm trying to be more aware.
Be a fantastic presentation.
We do have fantastic presenters, so. Okay, folks, it is 8:30, so I think we'll get started with our seniors mental health geriatric psychiatry teleeducation session today. Today we are welcoming Dr. Ian McKay, who is a geriatric psychiatrist that did both his medical school, his psychiatry training, and his subspecialty training here with this service. We're very proud to have him with us today to talk about alcohol use disorders in the older adult. Just a note that you can put your questions in the chat, and the links for evaluation and access to the presentation will be at the bottom of the chat at the end. So without further ado, I'm going to hand you to Dr. McKay.
All right, thanks, Sarah. Welcome, everybody. So there's quite a bit to cover today, and there's also sort of pretty broad group of different types of clinicians. So hopefully there's something for everybody today. So today we're going to talk about the relevance for mental health practitioners of alcohol use among the elderly, try and identify a couple of screening tools you might use, describe some cognitive effects of alcohol, apply knowledge of withdrawal syndromes and treatment to a clinical vignette, develop an approach to evidence-based pharmacological treatment. Again, a lot to cover, so it's going to be just touching on these things. And for those that do have time at the end, after we have a few minutes of questions, I'm going to do a sort of bonus case that I'd like to share with people if they're able to hang around. So about 75% of Canadians use alcohol. There's about 15,000 preventable deaths per year related to it, 90,000 preventable hospital admissions, 245,000 potential years of life lost. So the healthcare costs are about 6 billion a year, and if you include lost productivity and crime, probably around 14 or 15 billion. 20% of Canadians will meet the criteria for alcohol use disorder in their lifetime. So it's a pretty huge problem. So the baby boomer population, as everyone knows, it's larger than any other cohort, and they have a higher rate of use of drugs, alcohol being the most common than prior generations. There's a 29% risk of nursing home lifetime diagnosis of alcohol use disorder, 49% of veterans in nursing homes, 50% of older patients hospitalized on psychiatric units have an alcohol use disorder. So I recently saw this in the news. So potential of putting beer in corner stores, and there's been a lot of back and forth online about it. So will increasing access be helpful? Not too likely. Not when you think about the fact, and I don't have a direct reference for this, but if you think about the amount of alcohol that's purchased from liquor stores, and you think about the 10% of the top 10% that purchase that alcohol, the top 10% of buyers purchase more than 50% of the alcohol. So it's a fair bet that a chunk of those people have an alcohol use disorder. And so what we're doing is increasing access potentially to people who have alcohol use disorder to alcohol. And when you have a situation where someone may be abstinent and they avoid places like liquor stores, but then suddenly they're faced with a bunch of beer in a corner store, or just easy access when they couldn't drive to it before, but now they could walk to it. I do not personally, and this is my personal opinion, think that is worth any increase in sales. So compared to younger adults, older adults are more likely to hide substance use. They're less likely to ask for help. Their symptoms are more commonly misattributed by healthcare providers, and they're more likely to be underdiagnosed, misdiagnosed, undertreated, or untreated. And few really seek help in addiction services. So what's different about seniors? Well, they have increased sensitivity to alcohol. So they have a decrease in lean body mass and total body water. So that means an increase in the serum concentration of the alcohol, meaning that it's going to be more potent with smaller amounts. So that's increased central nervous system sensitivity, and drug-drug interactions are going to increase as well in that population who often have multiple medications on board. So older adults who do engage in treatment, they can have as good or potentially better outcomes than younger adults. And they're more likely to complete treatment. And it doesn't matter when you started drinking the alcohol. It could be something that's lifelong, or it could be something that you developed a problem with in later life. There's some evidence that forced abstinence, and I'm not condoning forced abstinence, but someone who required nursing home placement for potentially other reasons could also lead to improvements in ADLs, alcohol-related cognitive impairment, and sometimes even discharge home. So only about 7% of substance abuse treatment facilities have a senior-specific program, and that's actually a US stat. So I suspect that it's even less in Canada. But when they did have age-specific programming, it resulted in improved attendance at the meetings and treatment completion. And they're 2.6 times more likely to be abstinent at 6 months and 2.1 times more likely to be abstinent at a year. So how much is too much? So there's these, senior specific drinking guidelines, but they are outdated. So the 2023 adult low risk drinking guidelines are probably more relevant at this point, talking about a continuum of risk for people, including seniors. And, most importantly, really indicating that there's no safe level of alcohol, and less alcohol is better. So really 0 drinks per week, or potentially 2 standard drinks or less per week, and anything more than that, they talk about really significant increased risk of all alcohol related sequelae. So in our population, you would suggest avoiding alcohol if the person is frail and elderly, if they're at risk of falls, such as ataxia, cognitive or visual impairments, sedating medications like benzos or opioids, comorbid medical illness that could be made worse by alcohol, such as gastritis or ulcers, pancreatitis or liver disease, or mood disorders. So if you think about the people that we see, that is a very large chunk of those people that we would be suggesting that no alcohol is the safest option for them. So pretty much all of our patients should be asked about how much they drink and other substances. And you do want to pay special attention to patients who have a history of falls, head injuries, or failure to thrive. Those that are bereaved or have experienced recent loss, lonely, socially isolated, chronic pain issues, insomnia, those with dementia, depression, or anxiety. And again, that's an awfully big portion of the people that we serve. So the Short Michigan alcohol screening test has a geriatric version. It's freely available online. And it's just 10 items, so a score of 3 or more is indicative of a potential drinking problem. Although similar to CAGE, I would say anything more than 1 should prompt you to ask some more questions. The CAGE, most people are probably familiar with, so asking someone if they've ever felt they should cut down on the drinking, if they've ever been annoyed by others criticizing them, felt guilty or bad about the drinking, or had an eye opener. And it says, if you have 2 or more for men, that's considered positive, or 1 or more for women. But again, I would say if you get one positive for men or women, you should be asking more questions. And it's important to recognize as well that a previous history of heavy drinking, regardless of if they're abstinent now or not, imparts a five-fold increase in psychiatric illness. And it's likely that that illness is going to be more severe and chronic if they're depressed. So even if they were a heavy drinker in their 30s and they stop now, that's relevant to your history. So I'm going to pepper a bit of a case throughout this. There's based on real cases. This is Ethel. So she's an 81-year-old married female, primary caregiver to her husband who deals with moderate dementia. She's been retired over 20 years and really kind of reverted back to her young adult life when she hit her 50s or 60s. She's previously been very social, a lot of friends, regularly attending bingo and other social situations, referred for concerns about her memory, her mood, as well as her alcohol use. So lately, she's really not getting up from the couch very often. She seems quite vague and inconsistent, and she's reporting that she's having 1 2-ounce drink of vodka per night. However, there's empty bottles around the kitchen that she says belong to her husband. However, speaking with family, they suggest that it's probably upwards of 2 quarts of vodka per week over the last 9 months or so. And a trigger for this increase in alcohol use was that her husband had kicked out the grandchildren who had been visiting from overseas. So there was this progression of her disease. For the last 6 months, she's had low mood. She's been isolating more irritable towards her husband, not getting out of bed until noon or 1 p.m., and she's not been eating as much. So Ethel doesn't think that she has a memory problem, but her granddaughter indicates that she doesn't recall the appointment today. She needs queuing for the weekends when VON don't come in for medication, and this is for her husband. More derogatory comments on Facebook recently, like she has no filter. Functionally, she's got some impairment in her instrumental activities of daily living, including improper medication use. Her granddaughter has taken over finances as there's quite a lot of debt. So there's a problem with sort of how we name these problems with alcohol when they start to impact memory. And I don't necessarily have an answer for that, but it's important that we think about it. So much of the time we call something alcohol-related dementia when it seems like it's irreversible and they have a heavy alcohol use history. But there's not really a consensus definition, and you use a lot of clinical judgment in diagnosing dementia, saying that the alcohol and the issues related to the cognitive impairment are related. There's Wernicke-Korsakoff syndrome. So that's when you can develop a thiamine deficiency resulting in acute confusion, ataxia, and ophthalmoplegia, that if it's untreated, it leads to this irreversible retrograde and anterograde amnesia. And that's the one that a lot of people think of. Within the DSM-5, if you were trying to name a disorder of cognition related to alcohol use, you might call it a major or mild neurocognitive disorder, and then use substance abuse as an alcohol, such as a major neurocognitive disorder due to alcohol. For alcohol-related dementia, there is some data suggesting that younger age of onset of memory issues, like even below 60, typically male, unmarried, socially isolated, and there's often comorbid mental and physical conditions. You'll often see executive dysfunction and then also a level of visuospatial and memory deficit. And so these people can be more challenging to diagnose than someone perhaps with a more typical presentation like Alzheimer's dementia, because their memory initially may not be significantly impaired compared to some other issues like perhaps disinhibition and a change in their social behavior. So they're less likely to demonstrate language impairment, non-progressive or slower to progress, and they may have some level of recovery, perhaps even full recovery after abstinence. And that could be a matter of weeks, or it could be a matter of years. And so it's really important to try and figure out what the underlying cause may be, because there's a potential to positively impact the outcome if you intervene early. Unfortunately, seniors are less likely to recover from cognitive deficits with abstinence, likely owing to their baseline, decrease in cognitive reserve, and potentially, related to decades of substance use. So alcohol affects the brain in multiple potential ways. So it can be a direct neurotoxin. And also when you have this binge and withdrawal, so binging decreases glutamate, which is an excitatory neurotransmitter. And so it's depressing the central nervous system. And then when you stop actively drinking, then that depression is alleviated. And so then you have this rebound effect of increased glutamate, which in high levels can be toxic. There's also the potential of, or oral intake with heavy alcohol use, resulting in a thiamine deficiency. And then there's also the comorbidities and lifestyle. So there could be, someone with a heavy alcohol use history may also be a cigarette smoker and also have, vascular cognitive risk factors. So a trial that included 1.1 million patients with dementia between 2008 and 2013, using the French National Discharge Database, showed that 57% of early onset dementia patients also had alcohol use disorder. And alcohol was found to be the strongest modifiable risk factor for dementia onset. Alcohol was a stronger risk factor in this group than smoking, depression, or hypertension. So when you ask Ethel about her drinking, she says, it's just one drink. We often recognize that that's not always an accurate representation, and obviously it may not be a standard drink. So what are you going to do in this situation? So there's outpatient management for alcohol use disorder. So if you were going to try and work with this patient, then you'd require frequent follow-up. You need to continually ask about the drinking. And we do know that, in family medicine, family practitioners who interact with patients and ask about drinking and give a little bit of psychoeducation, it does have an impact on some patients in reducing or even stopping alcohol use. You want to review the low risk drinking guidelines with people so they understand that there has been a shift in our understanding of the impacts of alcohol over the decades, and that's important in a place like Nova Scotia that has a cultural proclivity for high alcohol use. And you want to identify any problems that seem to be caused or exacerbated by the alcohol. So, for example, if you note that the patient is coming in with complaints of, poor mood, poor sleep, poor energy, then you can highlight that that's likely to improve with a reduction in the alcohol. So that's sort of a part of motivational interviewing. So finding out where the person is in their desire for change, and then working with them at that level, sort of being curious around it. Try and understand whether they're looking to reduce the amount of alcohol that they use, or if their goal is to actually stop altogether. And if they're trying to reduce alcohol, really try and nail down some details about how this would come about, because vague ideas are unlikely to ever yield significant benefit. So, and then avoid tips around, give tips around avoiding intoxication. Try and record amount of drinks so that they can track their progress. Sometimes it can be helpful, to have, baseline lab work. I'd encourage it for everybody so that you can understand if the person might already have, sequelae from chronic alcohol use. Baseline labs like MCV, so looking at how big the red blood cells are, they tend to get larger with chronic alcohol use, and liver function testing can be helpful. So after a couple of weeks of regular heavy alcohol use, the GGT level, or that GGT enzyme, typically goes up. And then over a period of 1 month to a couple of months after abstinence, it typically would taper off. So if someone is more regularly using alcohol, then you might see a change in those numbers that would tip you off. However, there is a proportion of people who may be drinking heavily and their liver enzymes don't respond. And then those who are, closer to end stage liver disease as a result of heavy alcohol use. So with cirrhotic livers, for example, because their livers are sort of shrunken and fibrotic and scarred, they don't have as many liver cells that are working properly. And so when you drink a lot of alcohol, you're not actually damaging as many cells, and they're not releasing the same level of the liver enzymes. So in those people, their liver enzymes, they may actually kind of look normal, even though they've got severe disease. Try and review triggers with people about where they're drinking and what might help them stop. For example, if they go the same route past a liquor store every day, then maybe it's a good idea to take a different route. Give education for the patient and family about this being a disease, and then certainly pretty much everyone I would consider a referral for an addiction program if it's possible. The more support that you can get around this, the better. So remind them it's a chronic illness, not a moral weakness. The prognosis is good if the person is committed to change, and if you're able to provide appropriate treatment. And let them know that abstinence does have a higher rate of success rather than trying to just reduce. I think, a potentially poor analogy, I guess, is you think about somebody who wants to decrease, eating chips after supper in the evenings, and they could either have a giant bowl of chips in front of them and say that they're just going to eat two versus not having any chips in the house, and which one do you think is going to be more successful? So if they say they want to cut down but not stop, I would say try and agree on a specific trial period so that the person says, this is we're not going to do this sort of forever, because it may or may not work. It can always kind of get pushed down the road, and that may be a way to sort of avoid getting to what you need to do, which may be abstinence. So if they're drinking a lot, so it could be more than 6 drinks a day, but I would think more about what the impact of the alcohol is rather than how many drinks per day they're actually having. If they're having, a lot of anxiety in the afternoons before they resume drinking, or they're having a lot of, tremor around that time, that would be concerning that they may have more significant withdrawal symptoms if they were to stop altogether. There is a tool, the prediction of alcohol withdrawal severity scale, which can give you an idea whether or not the person is likely to require medical withdrawal management. Comorbid illness should be treated concurrently, and it could also be another red flag that inpatient detox is going to be required for that person. It's important to encourage general self-care, surrounding yourself with good people who have your best interests in mind, sleep hygiene, exercising, and trying to, develop non-alcohol related socialization. There's AA groups, Al-Anon for family and caregivers. Whenever there's issues, make sure you're reminding your patient of their successes, and that relapse, although not ideal, it is common, and it's a time to reflect on what went well and what didn't go so well, reconnecting with services, loved ones, and healthcare providers. And then over the last couple of years, there's been development of the outpatient withdrawal management program, and there'll be a link for that at the end. But that's more like a sort of like a day detox plus ongoing sort of management around alcohol withdrawal and other substances. For anti-alcohol medications, Patients should be offered medications when alcohol use disorder is diagnosed and throughout the treatment. So as long as there's no sort of absolute contraindication to these medications, they should be offered. So we know that people are getting more of these medications perhaps than they used to be, but it's still not nearly as much as patients would qualify for. They do reduce alcohol use. They have good safety profiles overall, and they tend to retain patients in psychosocial treatment. So you want to combine the medications with those other important forms of treatment. So quickly, naltrexone is typically started at 25 milligrams per day, and that's to try and reduce GI upset, which can occur. So you do that for usually a minimum of 3 days. If that's tolerated, then you would go up to 50 milligrams per day. That is the sort of standard dosing. Although, talking to substance use disorder experts, they would suggest that it could go up to as high as 150 milligrams in some people. But again, you need to watch the potential side effects. So avoid it if the liver function testing is more than 3 times normal, or if they're on opioids, because it will result in the person going into opioid withdrawal. There's theoretical risks around suicidal ideation and depression. It's no longer an exception status drug, so you don't need to do a lot of paperwork to get this going. And that's the same for acamprosate. So the dosing is typically 666 milligrams 3 times daily. So my preference is usually naltrexone because it's just once a day. And if someone has memory issues, then 3 times a day medications can be more of an issue. And it does need to be a lower dose if there's renal impairment. So 666 if it's normal. If it's between 30 and 50 mils per minute for their EGFR, then it would be half that. And then if they really significantly impaired renal filtration, then you would not use that drug. So naltrexone is good at decreasing the amount of alcohol that people use, as well as helping sustain abstinence. Whereas acamprosate has more evidence just helping people maintain abstinence. So typically you would want the person to be able to be abstinent for at least a number of days. I've heard 4 days before you would initiate acamprosate in order to have it be as effective as possible. And some would add thiamine, 100 milligrams or more. I'd probably say actually change that now to 200 milligrams daily, and vitamin B12. So I know some other people have started doing this, but I've started using B100 complex multivitamins once daily in a lot of seniors who have mood, cognitive, or substance issues, because it does have B12. It's got folic acid. It has 100 milligrams of thiamine in it already, so you're kind of covering a lot of bases with just the one multivite. In seniors, at least, so naltrexone, acamprosate, and disulfiram would have evidence as medications to use for anti-alcohol. However, disulfiram has a lot of side effects, and I wouldn't typically use it in seniors. There's been a couple of exceptions where someone's been using it for a very long time, and their spouse perhaps was dispensing it to them, and it worked for them. And I certainly wouldn't stop it in that situation, but most of the time I'd be looking at naltrexone or acamprosate. There's been a little bit of buzz around the GLP-1s like semaglutide, and that some of these people that are getting this medication for other reasons like diabetes are also noticing that it's decreasing cravings and alcohol intake, but a lot more research needs to be done on that. And there's other medications that are sometimes, considered. So topiramate, baclofen, gabapentin, but the evidence base for those medications is much less. So those are not ones that I would typically go to. Sometimes somebody's on gabapentin already, and you could think about trying to optimize that, but I would use naltrexone or acamprosate personally. And then there's also been a little bit of concern around the possibility that treating depression could somehow increase your risk of cravings. There's a link to an article about that here. But the bottom line from my perspective would be, if they meet criteria for depression, you're gonna want to treat that. And if you find that the person has a significant increase in cravings associated with initiation of an antidepressant, then you're going to deal with that at that time. So Ethel's granddaughter felt the process was going too slow, so she decided to water down the vodka dramatically. And unfortunately, within a day or two, Ethel was very sick. She was anxious. She was shaky. She was scratching at her arms and yelling at a man who was in her bedroom. She told her granddaughter people were out to get her. And Ethel seemed terrified when her granddaughter tried to comfort her and was screaming and ended up scratching her. So she ended up going to hospital. So if she was in a hospital, what would that look like? So there's inpatient treatment for alcohol. So it's typically for patients who have heavy chronic use and comorbidities, especially if there's been previous severe withdrawal, because there's this possible kindling effect, which means that you're sort of more predisposed after having one episode of withdrawal to have future episodes. And if someone has a lack of outpatient support, both social and healthcare, then it's going to make it a lot harder to treat them as an outpatient, and if they're very frail. So you're going to be looking at alcohol withdrawal symptoms. They're going to include increasing anxiety, agitation, irritability, and GI symptoms, seizures, tremor, hallucinations, sweating, possibly delirium, tachycardia, hypertension. They may have one or they may have all of those symptoms. It depends on the person. They'll usually begin within 6 to 12 hours after their last drink, often with some tremor, anxiety, and restlessness, a little bit of nausea, and difficulty sleeping. And those will usually resolve, if it's going to be mild, within a few days. Symptoms often peak between 1 and 3 days, and about 10% of patients will have more severe symptoms. They're going to have more tremor, profuse sweating, temperature is going to be elevated. They're going to be breathing fast, potentially hallucinations. And about 90% of withdrawal seizures are going to occur, between 24 and 48 hours, and they're often tonic-clonic seizures. And then delirium tremens will usually develop between day 2 and 3. That's going to occur with about 1 to 5% of your severe withdrawal patients, and it would typically resolve in 2 to 5 days after onset. And then acute symptoms would usually resolve in 3 to 10 days. So in 2020, Dr. Mike Butterfield and Dr. Nicole Hirschenhaus and a number of others did a paper called Inpatient Management of Alcohol Withdrawal Syndrome for acute psychiatric patients. So that was sort of a modified CWA protocol to treat patients on the psychiatric units who may potentially be going through alcohol withdrawal, and taking into account, comorbidities and that type of thing. So there's a link there for that as well, or you could Google that to get the paper. In elderly patients, typically you would use a shorter acting benzo like lorazepam rather than a long acting, which might hang around too long and accumulate. And they're more likely going to have a chronic history, so going to be at higher risk of things like significant delirium and withdrawal. So the recovery will often take longer, and if they're in withdrawal, absolutely treat them. You don't want to underdose. And this is just a headline I saw where someone in withdrawal required 1,600 milligrams of lorazepam in 24 hours. So in that case, it worked out for that person, and thankfully those people were willing to push that to get improvement. But it just shows you how varied people are. Some might need no benzos, and some might need 1,600 milligrams. So the important thing here for delirium tremens is simply that you've got alcohol withdrawal and you end up developing a delirium. So the two together would be delirium tremens. So it's not complicated, as complicated as it might sound. So you want to be on the lookout to identify that. It's going to occur, like mentioned, in 1 to 5% of patients with severe withdrawal, and the mortality untreated could be up as high as 35%. You're at risk of things like respiratory arrest and cardiac arrhythmias. If you've got comorbidities, but it is treated, your risk of mortality is around 5%, and it's less than 5% if it's treated. So in general, a very treatable issue. For post-withdrawal management, a protracted withdrawal can occur from between 2 and 12 months. So patients can have ongoing insomnia, some mild autonomic hyperactivity, anxiety, low mood, and there's not a lot of clear benefit to treating that unless they have enough symptoms that they're meeting criteria for its own DSM-5 diagnosis. But you can see this is going to be a very difficult time for people because, for example, if they were self-medicating an anxiety disorder with alcohol, and withdrawal from alcohol is causing mild autonomic overactivity and anxiety, they're going to be at high risk of relapse. If a patient has significantly depressed mood related to the depressant effects of alcohol, usually that would resolve within about 4 weeks. But if they appear depressed, they can't stop the drinking, or they're really high risk, you should treat the depression. So outpatient withdrawal management, so they have things like structured relapse prevention, so understanding your substance use, triggers and cravings, coping skills, creating a plan. AA, as mentioned, can be helpful for some, and then the ongoing use of anti-craving medications. And some patients might only need it for a period of time, but often they need it for longer periods, so a year or longer. So Ethel unfortunately had a prolonged delirium in hospital and had incomplete resolution with severe functional impairment initially. She ended up being placed eventually in long-term care, and there was she was able to be abstinent in long-term care. She was followed by seniors mental health, and there was significant improvement over about a year, but there was a significant amount of executive dysfunction which remained. Without insight into the deficits or need for assistance, she required ongoing being in long-term care on an ongoing basis. However, she did enjoy her time with her granddaughter. So I went pretty quickly through that because I wanted to see if I could get through all of this in the time, and I did. So I added in some resources here. There's a handout. It was created at DAL around alcohol use disorder medications. This is for patients. And then the second link is another DAL thing where they sort of in a more in-depth fashion compare and contrast naltrexone versus acamprosate, including cost and that sort of thing. The Canadian Coalition for Seniors Mental Health has guidelines on alcohol use disorder, and there's a link to that as well, and it's pretty helpful. And then outpatient withdrawal management, there's just a link to the mental health and addictions site for that. So if people are up for it, we can go through this bonus case. And so this is based on a real patient. I do have, consent to discuss this in any sort of forum by the substitute decision maker because they want this information shared. So this is a 75-year-old lady. She was living with her husband in rural Nova Scotia. She was admitted, and this all occurred a number of years ago, admitted to hospital after a motor vehicle collision while intoxicated. She was diagnosed with a first episode of mania as well as an alcohol use disorder. So she had been excessively spending, she had poor sleep, she was more intrusive and demanding, and she had increased alcohol use over a period of a few months. Alcohol was, a longstanding part of their social lives. They had frequent gatherings and loved having, parties and visitors and that type of thing. But both denied it, her and her husband denied that it was ever particularly problematic until she became manic. And there was never any history of driving under the influence prior to admission. So she was on a few medications. She took a couple of supplements that she showed me. She was always worried about her weight, her appearance, and had, mild anxiety throughout her life, but was very highly functioning. There were never any cognitive concerns prior to admission. She seemed to have some mild impairment in hospital, but that bounced right back after discharge. And while she was in hospital, she was started on valproate as well as risperidone to treat the mania. And then she was quickly titrated up to 100 milligrams twice daily of naltrexone for alcohol use disorder. And so, as you'll probably remember, I talked about 50 milligrams once per day being the normal average dose for treatment of alcohol use disorder with naltrexone. So she was on 100 twice a day, which is quite a high dose. Her license was revoked secondary to the combination of the mania and the alcohol use while driving. And then she was referred to us on discharge from hospital. So I saw her a couple of weeks after she was discharged. She had poor appetite. She was shaky, anxious, denied alcohol use, since discharge or since hospitalization, I should say, and her husband agreed, and they were pretty much always together. So it wasn't, a matter of her sneaking away. And naltrexone was tapered because she had very poor appetite, had lost a large amount of weight in a very short period of time, um, and despite tapering that, she continued to do very well, and wasn't drinking. And at the same time, when I first met her, we also got her started on some thiamine. Unfortunately, she had a very complex course, and for a long time, she didn't have to go back into hospital, but it required really sort of closely following her because she was on valproate and risperidone, and with the valproate, she developed megaloblastic anemia and then pancytopenia. So we were sort of slowly tapering that, trying to do it as quickly as we could, but also not wanting to precipitate another episode of mania or land her into a depression. She was started on folate. So, typically if you look it up, valproic acid isn't necessarily associated with folate deficiency, but a lot of the anti-seizure medications are. However, there's some evidence that it might interfere with folate metabolism. And so given the megaloblastic anemia, I started her on some folate anyway. She then developed some Parkinsonism on the risperidone, and so we were tapering that down, and then developed akathisia. It was pretty awful. She would spend hours like trying to get in and out of her bed, like she just could not settle. Her anxiety was severe. Her mood was low because of all of the stuff that was going on. Her Parkinsonism was quite severe. And eventually we were able to get her onto some escitalopram for the mood and anxiety, tapered the valproate and the risperidone, and then titrated while we were titrating up some quetiapine to help sort of cover the potential for mania. So over a 2-year period, her mood and anxiety really improved. The akathisia and Parkinsonism resolved. Her anemia and pancytopenia resolved. She wasn't using any alcohol. So after a couple of years, she wanted to try and, only be taking what she absolutely needed. So we did stop the thiamine and her folate as well. She wasn't on the valproate, so she didn't need that anymore. She was, quote unquote, happy to be back. Her family was ecstatic about how she was doing. We were able to write a letter to the DMV, and she retested, got her license back, and there were no issues with that, was driving and socializing well. Unfortunately, about 6 months after that, she seemed off to her husband. She seemed to be spending more money again. And so I saw her and recessed her, and I was a little worried about the fact, often in bipolar disorder, if you can get away with it, when someone has a depressive episode, you would treat that depressive episode with an antidepressant, but hopefully taper and discontinue it once the person is euthymic again, because it can cause potential problems. In this lady, we talked about the pros and cons and kept her on the escitalopram longer term because she was doing so well on it, and she was scared that she was going to have more depressive and anxious symptoms if we tapered it. Given that she was starting to seem a little bit hypomanic, we decided to taper it. But within a week, she started to get terrified that she couldn't walk. She was appearing very weak. Her husband called 911. She was assessed in hospital for a couple of days. They couldn't figure out exactly what was going on. It was around, Christmas time. And so they opted to go home and see if they could manage there. But ended up back in hospital. She was confused, unable to use her arms or walk. So she ended up being assessed by neurology. And unfortunately, the MRI showed evidence of Wernicke-Korsakoff syndrome. So, again, Wernicke encephalopathy is this acute, potentially reversible swelling of brain structures, whereas Korsakoff syndrome is sort of the downstream sequelae of that with an irreversible memory disorder. It's caused predominantly by thiamine deficiency in a variety of situations, but heavy alcohol use is one of them, and probably the most notable. Her husband denied that she was drinking any alcohol, as did she, although she was so confused, it was difficult to get a straight history from her. So he ended up searching her belongings at home and found hundreds of little bottles of health supplement in her closet. And this is what he found. It's called Rescue Remedy. So you're supposed to take a few drops a day to help support yourself in times of emotional demand. Turns out it's 27% ethanol. So this lady had been drinking several bottles a day, likely for several months, instead of the, up to 4 drops per day, which is recommended. So, what exactly happened here? Was this an alcohol, she started using more of that and then that induced a mania, or did she start to become manic and then started using more of that substance? We don't really have an answer for that. But unfortunately, she was in hospital for months and she was severely cognitively impaired. She was unable to walk, initially unable to use her arms at all. I did reach out to Health Canada and put in sort of, I guess, a complaint just to let them know that this substance is out there, that that there was this very adverse event related to it, to see whether or not, based on their investigation, something could be done about the labeling or something to try and reduce the risk to the public that this might ever happen again. It seems like it might be a 1 in a million thing, and maybe it is, but anything to prevent that from happening again would be a worthwhile endeavor, I think. So she wasn't able to return home, and she now resides in long-term care. Her mood has been stable, and I have seen her in follow-up, but really she doesn't need much follow-up at this time because things are going fairly well for her within that context. And really left with a lot of questions about how this happened, and how things might have been done a little bit differently, and I just wanted to present it as a bit of a cautionary tale. So that's the end of my presentation. Thanks for listening, and I think we still have a couple of minutes for questions if anybody has any that I might be able to answer for you.
Thank you so much, Dr. McKay. That was really interesting, and I particularly appreciate both cases and how challenging this is. Really difficult, particularly when you have people end up either in hospital or long-term care who you can't get a history on, who you don't know what's going on, you don't know what's happened in the interim years. So really great to keep that on our radar in terms of alcohol use as being a potential trigger for some of the symptoms. Just looking at the chat here, we've got someone asking, wondering what the age is for older adults in this presentation. So they're wondering about what we're considering to be older adults.
Yeah, so most of the literature would say 50, 55, actually. And in part, I think that's related to the sort of physiological aging that occurs in patients who are chronically using substances.
I was talking with one of our colleagues recently about the unhoused population, of the large number of people in Halifax and Nova Scotia who are unhoused, and how when one is unhoused, particularly chronically, your health status deteriorates much more quickly. So people who are, in their 40s and 50s have the medical problems and sort of the physiologic problems that we would expect of people much later, 70s or so. So that is something to keep in mind as well.
Yeah, absolutely.
There are some thank yous there. Does anyone else have any questions or comments for Dr. McKay?
Clear as mud.
All right. Well, no, it's actually extremely informative, even for those of us who've been doing this for a long time. It's not something that we talk about a lot. And I think until sort of the last couple of decades, we didn't even really ask seniors about their alcohol use to the extent that we do now. And we certainly didn't ask about drugs as well. So there are links on the chat to the evaluation and link for attendance if people would like those. And I'm just noticing here that there's been some other posts. Someone said inpatient addictions medicine consult service is a resource at the Halifax Infirmary. That is true. And then there's lots of thoughts or lots of thank yous to you, Ian, for being so relevant and pertinent. So with that, I think we will sign off, and people, please feel free to send in your evaluations and get your credit for attendance, and we will see you in 2 weeks when we have a presentation on MAID done by Dr. Terry Chisholm and Dr. Shiloh Goshen. We'll see you then.
Thanks, everybody.